that's going to help out your patient right now. So what happens with CPAP that doesn't happen with NRB is that, say this is, so we'll keep this fluid here. This is your bronchial. So obviously it's going to come in from your upper airway, trachea, bronchi, bronchioles. And this is still a fluid. This is that blood that's backed up, right? So what the CPAP does is going to send in pressurized air, and what that pressurized air does is that it temporarily pushes the fluid back to the tissues around the alveoli. And when it pushes that air out of the way, it allows for temporary gas exchange. That's all it does.
So as soon as you turn off the CPAP, the fluid will go back in?
As soon as they breathe out, that fluid will go back in. So when that patient is breathing in, they got their volume breathing in, plus the CPAP gives them an extra kick. And that extra kick is what's gonna push that blood away, allowing for gas exchange to occur. That's all it does. So that's why it helps drowning patients and pulmonary edema patients. Make sense or no?
Yeah.
It's simple.
It pushes it away into
The tissues around. It's gonna push it away into the tissues around the alveoli. And it's gonna allow that temporary gas exchange.
How would they fix that permanently, you know?
You can't really fix that. But this patient has CHF, a new heart.
Let's say he was drowning though, so it wasn't.
Oh, then that would just go out by itself.
That would just diffuse on its own eventually.
Yeah, eventually. No, just But if it's CHF, they need a new heart. Or eventually, if it gets so bad and they have the money for it, they'll get what's called a left ventricular assisting device. But that's like they have money with.
That's the one that has continuous pulse. You can't take a pulse reading.
Yeah, you can. So
Continuous flow,
so it's a machine they have out here, and they have a hose that instead of going into their heart, it goes to the machine gets the blood and it pushes it out into the body. It's kind of cool.
So there's no pulse
They don't have a pulse.
or systolic.
That sounds about right. I don't know about that one, but it sounds right though. I mean, it makes sense. But that's pretty cool.
Yeah, because it's all one.
So yeah. But usually, people that have that, they have a heart coming. Like there's one coming. All right. Any questions about that? I think you covered it pretty well. So CHF leads to pulmonary edema. Pulmonary edema leads to difficulty breathing. This patient can benefit from the CPAP, and we know why. This is gonna push that fluid out of the way for a while. Whew. So maybe we'll talk about that when it comes up. For right now, let's go back to the slide. You guys are good with this, I think. So let's go on to the next one. So rhonchi and stridor. We talked about stridor. Rhonchi is something that should be that's mucus buildup. People that have that, they have what's called, and this falls under COPD, chronic bronchitis. Itis means inflammation. So if they have COPD, they have chronic bronchitis, plus another disease, another illness. And we'll talk about it when we get to the crazy. Okay, so chronic bronchitis is exactly that. So this is your bronchioles, right? Bronchioles, so they get inflamed, but that's not the big issue here. The big issue with chronic bronchitis is the mucus buildup. So I'll use this right here as an example. So what happens with chronic bronchitis, we'll go back to the bronchial, is you have this excess buildup of mucus. There's too much mucus being produced, and that's the real problem with chronic bronchitis. The name doesn't even explain what the real issue is. So it's chronic bronchitis because yes, they are inflamed, but the real issue with chronic bronchitis is the mucus buildup, and that's when you get the rhonchi. the bronchitis from the mucus buildup. Now, why that happens? The main reason, besides genetics, besides your parents, the main reason is their environment. So a lot of people that have chronic bronchitis, they're heavy smokers, or they were raised in a place where there was a lot of smog, smoke in the air, toxins in the air. Do you guys recall what the job of the mucus is?
Supposed to move like toxins.
To trap those toxins, right? So what happens is you have mucus membranes. So mucus membranes are like little pumps. They're little pumps that make mucus. And what happens with them is that the more toxins that are introduced in the air that goes into your airway, these little X's represent toxins, the more toxins that go into your system, the more they pump. The more they pump. The more they pump, like when you go work out, the bigger they get. So these are gonna become bigger, and the bigger they get, guess what? The more mucus they produce. And once they get big, they stay big. Unlike us, they have to keep it up. So they're gonna be producing more and more mucus, more and more mucus. And these are your smokers usually, or people that are raised in really bad air environments.
So the fresno.
Yeah, fresno is known because of the cows and stuff like that. Yeah. So again, the mucus. So it's the mucus membranes, and it's from that toxins that come into your system, the airway. Any questions about that? And of course, because they're pumping, the mucus membranes are in the lining, they're going to irritate the lining, and it's going to cause chronic bronchitis. I'll leave that alone. And yeah. So again, chronic, just tie this together. Bronchi caused by chronic bronchitis. That is chronic bronchitis. The bronchitis comes from that mucus, that mucus buildup that I was talking about. All right, I'll leave it alone. All right, evaluating vital signs. Changes which may include increase or decreased pulse rate, changes in breathing rate, breathing difficulty, assure adequate ventilation, air breathing inadequate, begin artificial ventilation. So, Brian, give me an example of a patient, or give me a patient that you would ventilate, that you think you would have to ventilate in this scenario.
Someone who's not breathing by themselves.
Okay, athlete. Adrian, give me another patient besides one that's not breathing that you would have to ventilate. You feel like you would have to ventilate.
Someone who's drowning or they have liquid.
How do you do that? Manuel, give me somebody else you would have to ventilate.
Shallow breathing.
Shallow breathing. So, shallow breathing. So they don't have enough tidal volume, right? They may be breathing between 12 and 20 per minute, but if they don't have enough tidal volume, shallow breathing, you would have to ventilate that person. Mia, give me another patient you would have to ventilate.
Slow breathing?
Slow breathing, below how many per minute?
10, 12, below 10, 12 minutes.
For sure 10. Below 10, you're gonna assist ventilations. So those are your different examples.
Couldn't you say anybody that doesn't have normal breathing? It seems like basically anybody that's adequate or below.
No, because it goes again with like the vital signs and then patient presentation. Because like you just got done running like 2 miles really fast. You know, you're just running. The patient still compensating. Like again, it goes back to are they compensating by themselves or not. So are they in failure? Miguel, what is this whole thing called?
Regulator.
Nate, what is this thing right here called? starts with the F.
I'm lost. No,
Mia. What's it called? You guys need to know this stuff.
The flow rate?
What? You almost had it. What?
Flow rate?
Flow meter.
Flow rate.
I'm picky about this because you're gonna hear these terms on the NREMT, and if you don't know it, it's gonna throw you off. Like, what the hell is that? Now you know what it is. Okay. Flow meter regulates the liters per minute that is delivered to your patient. The whole thing is a regulator that is your flow meter. Yeah, something like that, John. Adrian, on this gauge, where do you want this gauge to be at? When you get to your rig, to your ambulance, you're checking on your stuff. Where do you want, when you put the regulator on the little green bottle, where do you want this to be at?
You don't want it to be like full or in the green.
In the green, or what? 2000. Okay. And Ryan, the little green bottle that you would have with you on your rig, on your gurney, you know what classification of bottle that is?
D
D, perfect.
or super D.
Maybe Super D?
Maybe.
I think it's just D. I don't know.
They gave us like 8 of them
Yeah, let's say
yesterday.
it was like 5 or 6.
We got D,
It's like
C,
F,
D,
H,
A,
F, M.
Alright, Mia, what's the E? The E cylinder. Where would you see that? How does it look and where would you see that?
On that side.
This chapter has been covered, right? Or no?
We did a little bit of it yesterday.
The way
This is
she
the one that
divided
actually
it
has
up,
the
well,
little
the thing
dolly.
was that 3 of them are portable and then 2 of them are mounted, like in the ambulance. And I
Okay.
think it was like D, Super D, and E were portable.
I didn't remember Super D. I learned a lot about that.
H, A, and K were.
Yeah,
There was just a chart.
Yeah,
that
chart.
had the
She
name
showed me
and how
pictures
much
of
it
it.
was.
It's
Yeah,
like
and they're just different sizes.
Yeah.
She didn't really explain it very well.
So the E is what again?
625 liters. But it's, when I looked it up, it seems to be the little one that people have, you know, like when they're wheeling around their oxygen.
So the E is a longer version of the one you guys have, the D. So it has the same circumference around, it's just longer. And that's the one that's in clinical settings, the one that's prescribed to people with COPD. So they'll have it. Like grandma and grandpa have it with the nasal cannula, like Disneyland.
Yeah.
Yeah, that's what you see. Alright, breathing difficulty, place patient in position of comfort. Administer, prescribe, oh, this is for your asthma patient now. You just went to asthma? I didn't see asthma anywhere until now. Oh, well, actually, an inhaler, sometimes your COPD patients will also have an inhaler. That's true. So it's not just. Okay, administer continuous positive air pressure. So in case you guys don't know this, besides CHF, besides drowning, your COPD patient can also benefit from the CPAP. And the reason they benefit from the CPAP is not because it helps with chronic bronchitis, it helps with the other illness that makes COPD. So for somebody to have COPD, they have to have 2 illnesses. They have to have chronic bronchitis and they have to have emphysema. Write those down. If they have those 2, they equal COPD, chronic obstructive pulmonary disease. That might be a I don't know, you're right. Emphysema. And then right now in a little bit, I'll talk about what emphysema is. I already talked about chronic bronchitis over there. Now I'll talk about what emphysema is and how they benefit from a CPAP. So again, this patient, CPAP. This patient, CPAP. Do this. Alright guys, now, the whole BBM thing yesterday, I'm not gonna ask who it was, I don't really care, I don't want to get anybody in trouble, but we are retraining the instructors, that's one of my things that I'm doing here. Now, did they say that they are always going to use it, like even with the cardiac arrest patient by themselves without another person? Was that what was said pretty much? That contradicted what I said? Cause I just wanna remember how to notes, cause I'm gonna have a meeting with the instructors and I'm gonna retrain them on what's right and what's wrong. So what they said was that they would use a BVM no matter what, even if there wasn't another partner during CPR? I'm guessing that's what they said, right? Yes? No?
I think the text actually says it's best to use two-person,
Yes, but
but I'm not sure what they said.
Okay, I'm just gonna go ahead and say that. I understand if you ever wanna say. I get it.
I just don't remember what they said.
I don't recall.
I don't know if they actually discussed it, but in the text it does say, it's recommended to.
I've been taking my notes, that's all. Cause part of the reason that I'm here is to like fix the program, and I gotta like just get them, make sure you guys are like being told the right information. It's all good, it's all good, no one's gonna get in trouble. Alright, so for emphysema, this is the issue. With emphysema, usually, let me back up. Alveoli have like an inner structure. They have like these walls that hold up the alveoli. Alright? With emphysema, the same issue that makes excessive mucus with chronic bronchitis will also break down the inner walls from too much toxins. And when these walls are broken down, the alveoli goes from a nice plump grape structure, nice and round, to a shriveled up raisin. Now the issue with this is that now we have less surface area for gas exchange to occur. Just shriveled up. And this is the reason why your COPD patients will benefit from the CPAP. It will blow it up to allow for more gas exchange. Okay. So this is emphysema.
Looks nasty.
It is. That's from just
Smoking?
mainly smoking. And then if you happen to have this down the road and you never smoked, you take your grandparents, your parents.
So, if you stop smoking, will that go away? Or is
Nope,
that
you got that for life.
That's
Nice.
permanent?
I got that for life. Just like that fat in the coronary arteries, you're married to it. Once you get it, it's not gonna go away. It's almost like marriage for some people. Can't get away. The CPAP, my little thing. So if you want to get your verbiage, we talked about what it does, how it works and everything. So I'm not going to talk about it again, but if you want to get your verbiage, there it is. Go ahead and read over that. I already went over it, talked about it. So you guys just stared at it, so it's going to click away. Alright, so common uses for CPAP, we talked about this, pulmonary edema, mainly CHF, drowning patients, we talked about asthma, COPD. We know why COPD patients will benefit from it because of the emphysema, which is part of the COPD. Again, for a patient to be considered to have COPD, they have to, at a minimum, have chronic bronchitis and emphysema. And for a patient that has asthma, they just throw it in there in a collection. All right, like they just throw it out, that's part of COPD now. But they have to have these at a minimum. All right. Respiratory failure in general, it's not a bad idea to give it to them. The only time that is a bad idea to give somebody a CPAP is if there was trauma. If there was trauma and there's suspicion that their lung tissue might be affected. So if someone had trauma and after trauma, physical trauma, they were having difficulty breathing, I'm gonna think that they may have a pneumothorax. Who can remember what a pneumothorax is, or tension pneumothorax?
Pressure just getting Air
buildup.
or outside of the lung?
Both of those are right. So you have air. So let's go ahead and so we'll see these are the lungs. Let's say that this patient got a baseball bat to the chest and it tore the lung tissue right there. So now, but the skin is intact. But remember, energy is not destroyed, energy is transferred. So if you hit somebody with a baseball bat, their skin might not be broken, but the energy continues and it might tear something down the road. So now what's gonna happen when they take a breath in, that air is gonna escape outside, causing pressure buildup. So if I was to give somebody that had this problem CPAP, I'm gonna rush air out and cause more tear and make that problem worse. So this patient should not get a CPAP. Okay? You even more. You're gonna just pretty much speed up the process of that. So anyone with a suspected pneumothorax or suspected tension pneumothorax will never get a CPAP for this reason. All right. Contraindications for a CPAP, here you go. I would document these down. Severely altered mental status, lack of normal spontaneous breathing. So they do have to breathe on their own for them to get the CPAP, okay? Because it's pressurized air, but it's not pressurized enough to ventilate the patient. It just gives them an extra, like little oomph of air. You actually have to ventilate someone that's not breathing. Inability to sit up. So pretty much if they can't breathe on their own, or they may have difficulty breathing, if they can't communicate with you, we're not gonna give them a CPAP. They have to be conscious, awake, and breathing on their own for them to qualify for a CPAP. It's pretty much down what it comes down to. Hypotension or shock, we don't wanna give them a CPAP because because the CPAP can actually drop the blood pressure a little bit. It can affect it a little bit. So if they're already hypotensive, it's gonna drop their blood pressure a little bit more to where it could kill them. And that goes back to what it's like taking away from that negative pressure. You guys should know about that by now. All right, you guys are good? Oh, wait, no. Go ahead, take a note. You want to finish up? Good? Nausea, chest trauma. We talked about why chest trauma. Nausea because they're gonna vomit. It's gonna push that vomit back in, causing aspiration. Shock's the same thing as hypotension. If they're in shock, they're gonna be hypotensive most likely. Upper GI bleed, same thing. We don't want to push fluid down their airway, so if blood's coming out and we have that CPAP blowing in their face, you could potentially push that blood down their trachea. That's bad. That's bad for business. Conditions preventing good mass seal. The only patient that I can think of, facial trauma, or the one that comes to mind is someone that normally has dentures in, but for some reason they don't have them in right now. Like they forgot them or something.
Beards.
Beards too, potentially. Yeah, no, that's a good one too.
Maybe take them up in the middle of the night.
Possibly. They don't have that structure. And also I'm thinking about that because that always comes up with the NREMT. Dentures. When it comes to so a question you might get is if a patient has dentures, should you take them out? The answer is going to be no. And the reason why is because the dentures are actually helping make that outer structure of the mouth that's going to help you with the seal. So we never take them out unless they get dislodged and become an obstruction themselves, then you would take them out. That's the only time.
So how would you ventilate a patient without injury if you can't get a proper
You just try the best you can.
try the best you can?
That's what you can do. Yeah, there's no real.
What if you just cannot get a seal
You start praying, because you can't do your job right. Actually, that would be an advanced question. So possibly happen with that patient. This is just me just thinking of stuff that I heard of. Maybe if like the airway management is 100% crucial and they need airway management to secure the airway, they'd probably sedate that patient, give them like something that would like make him knock out, and then put an advanced airway on their throat to secure that airway.
We're EMTs, we're not medics, so we just.
No, that's the only answer I have for you. There would be an advanced answer. That's what I'm saying. So you would just pray.
Yeah, so we just do that dispatch.
You would call for advanced life support.
Just try to dispatch if we can.
For additional resources.
Yeah, no, that's what you would do. As an EMT, your answer would be call for paramedics. So because they have that endotracheal too. So side effects, hypotension. Again, hypotension is that we're dropping that blood pressure, we're taking away from that negative pressure. Because every time that diaphragm goes down, it helps with air coming into the lungs, but remember, it also helps with bringing that blood down to your ventricles, right, to maximize blood flow. So if we're pushing air in, we're kind of taking away from this a little bit. So it's going to cause hypotension. And then something else that could potentially occur is a pneumothorax itself. So CPAP can create a tension pneumothorax. Most likely, if that were to happen, that's going to be like an older patient that's really fragile. Membranes get skinny and thin, and so you could possibly tear it. Increased risk for aspiration. The aspiration again goes to your patient that if they're vomiting or have an upper GI bleed. Aspiration means that something's going down the trachea. All that means. So that would be those patients. Drying of corneas. That's mainly an issue with infants when they could like become blind or something like that. Or that's in the textbook somewhere. You'll come across it. Just air. The air just blowing in, just drying out. Okay, that's situational. Every situation. See, explain procedure to patient. So you always want to tell the patient what you do. So like even if I was to get a blood pressure on Adrian, I'm like, hey, I'm gonna get your blood pressure. Like, cool? And then you do it. Start CPAP at low, and then go from there. So she's just checking the blood pressure to make sure that it didn't go down. Because Brian, what can a CPAP potentially do to the blood pressure? Could drop it. Adrian, why could that CPAP potentially drop that blood pressure?
Because you keep pushing too much positive air into the lung.
Okay, I'll stop you right there. And that's affecting what? That positive pressure is affecting what? Affecting cardiac output. Oh, okay, cool. I'll take that. That's good. You guys are on track. All right. If patient becomes worse, remove CPAP and begin ventilating patient. And then use that worse. All right. So now we're in COPD. So I talked about what COPD was. COPD is gonna be this right here, chronic bronchitis, right? That excess mucus plus your emphysema. Those two, at a minimum, make COPD. They have to have both for it to be COPD. So go ahead and get your verbiage. If you want, I will get it down. You guys need to know what COPD is. This trips out a lot of patients, a lot of EMT students, because they don't really comprehend what it is. But all it is just two illnesses. That's all it is. If they have those two, they have COPD. Simple.